This is Dr. Jeffrey Weber. I'm a medical oncologist at the Laura and Isaac Perlmutter Cancer Center here at NYU Langone Health in New York City. Today I'd like to report to you about three abstracts presented at the recent ASCO meeting in Chicago just about a month ago, which I think have a significance and importance as they relate to melanoma practice and care. The first one was a phase 1/2 trial of the new LAG-3 antibody fianlimab with the established PD-1 antibody cemiplimab, and this was an interesting phase 2 study with an initial dose escalation with a rapid accrual of patients to expansion cohorts, where 40 patients were treated in one cohort who could have been PD-1 experienced. Another 40 patients were treated who could not have seen prior PD-1 or PD-1 CTLA-4. And finally, there was a third cohort of another 18 patients for a total of 98, where patients could have seen PD-1, but had significant negative prognostic factors. And the amazing thing was that in this PD-1 LAG-3 trial, the response rates were fantastic. The response rate in the initial and then the second cohort, each of about 40 patients, were very high in that you had a 60-some-odd% response rate, 63% in both of those cohorts, evaluated by the investigators, and you even had a 56% response rate in the PD-1 experienced cohort that had the negative prognostic factors like liver metastases or prior brain metastases. And you had a 13% rate of complete responses in the first two cohorts, which comprised 80 patients, not a trivial number. The median progression-free survival has not been reached because at 12 months of follow-up, it's 52% progression-free survival, but the projection is about a 14 or 15-month median progression-free survival. And if you look at the toxicity, the grade 3, 4, 5 immune-related adverse events are only about 13%, which is not much more than you would expect with PD-1 antibody alone. So when you think about it, the LAG-3 antibody fianlimab with PD-1 antibody cemiplimab had an impressive response rate and pretty impressive progression-free survival in newly diagnosed melanoma patients. Admittedly, it was a heterogeneous group. Some of them were PD-1 experienced, some of them not, but most of them were not. And the treatment-related toxicity was similar to cemiplimab alone at 13% grade 3, 4, 5 IRAEs, although interestingly, it looked like you had more, relatively speaking, more endocrinopathies. The cemiplimab plus fianlimab performed well in the poor outcome patients in that small 18-patient cohort, including those who had high LDH or liver metastases, where PD-1 antibodies alone tend not to do very well. And I think clearly this combination has a lot of promise, and it's now involved in a randomized phase 3 study versus either cemiplimab or pembrolizumab alone. And it's also involved in an adjuvant study in stage 3, 4 resected patients who will receive the combination versus standard pembrolizumab. We then heard an update on the KEYNOTE-716 trial. This is again a trial that led to the registration of pembrolizumab for resected stage 2B and 2C melanoma. This was a multicenter randomized blinded, double-blinded, placebo-controlled study, phase 3 study, of over 950 patients who were randomly allocated 1-to-1 to receive either pembrolizumab for 17 cycles over 1 year at the standard dose of 200 milligrams every 3 weeks intravenously, or a placebo for the same number of cycles. And in this trial, if you recurred, you could get a guarantee of going back on pembrolizumab, especially if you were on the placebo arm. And the data that were presented, that was the update, were distant metastasis-free survival data. And at a median follow-up now at a pretty healthy 39 months, the hazard ratio for the distant metastasis-free survival is a very nice 0.59. We're looking at 36 months, 84 versus 74. So that's an absolute difference of 10 percentage points. And if you look at the DMFS by stage, we're looking at 86 versus 78 for the 2Bs, who do pretty well, and 80 versus 68, which again is a pretty healthy difference at 36 months for those who have the 2Cs, and the hazard ratios were either 0.62 or 0.57, which again I think are very nice and would suggest there's clear benefit for adjuvant pembrolizumab in resected stage 2B and 2C melanoma. If you look to the primary endpoint, which has already been presented at earlier follow-up, which is recurrence-free survival, now at 36 months the hazard ratio is 0.62, 76 versus 63, a healthy 13 percentage point absolute difference. And again, if you break it down by stage 2B or 2C, it's 79 versus 66 or 71 versus 58. Obviously, the lower figures coming in the 2Cs compared to the 2Bs, who will always do better. But still very nice, consistent data with hazard ratios of 0.58 and 0.65 for the 2Bs and the 2Cs. And some significant points to remember with now more follow-up on the Keynote 716 stage 2B, 2C adjuvant trial. It is now with longer follow-up, we're at 39 months. The hazard ratio for the primary endpoint of recurrence-free survival of pembrolizumab versus placebo is maintained. It's 0.62. The difference in recurrence-free survival is very nicely seen for both 2Bs and 2Cs and very similar in terms of hazard ratio. And again, for patients with resected stage 2B, 2C melanoma with now 39 months of follow-up, there is a definite difference in distant metastasis-free survival, which a lot of folks think is a surrogate for overall survival, with the benefit for pembrolizumab compared to placebo of a hazard ratio of 0.56, reflecting a 44% reduction in the risk of distant metastases, and that difference was seen for the 2Bs and the 2Cs, and no new toxicity signals emerged with longer follow-up. We also heard longer follow-up from the Relativity 047 study, which again was a different kind of study. This was a study in metastatic disease of patients who received either the PD-1 antibody nivolumab with the LAG-3 antibody relatlimab or nivolumab alone. It was a straight one-to-one double-blind randomized phase 2/3 trial, 714 total patients. And again, primary endpoint was progression-free survival in this study of patients with metastatic melanoma. And we now have updated progression-free survival, which still shows a significant separation. The hazard ratio is 0.81 currently, and the projected 36-month difference, the absolute difference in PFS, is 31 versus 27, with follow-up that's now at about 25.5 months. And again, the median PFS was reached at the initial assessment, which led to the registration of nivolumab relatlimab for patients with metastatic unresectable melanoma, and that was 10.2 versus 4.6 months, so those medians haven't changed. What's changed is now longer follow-up, with the curve of the combination clearly still continuing to be above the curve of single-agent nivolumab alone. And if you look at the survival data now seen for the first time, there's also clearly a difference. The curve of Nivo-Rela clearly is always above Nivo and breaks apart literally within the first 6 to 12 weeks. And at a projected 36 months, now with 25 months of follow-up, we're looking at 54% versus 48% overall survival with a hazard ratio of 0.82. Again, looking like it's still considerably different. And interestingly, if you look at what we call PFS2, that is the progression-free survival after the first progression, there's interestingly and almost surprisingly a clear benefit for the combination of nivolumab relatlimab compared to nivolumab alone. At a projected 36 months of follow-up on the Kaplan-Meier curve, it's 46 versus 36 months. So again, or percentage rather, 10 percentage points absolute number of patients who survive without progressing, that is PSF2. And again, if you look at the median PFS2, it's 28 versus 20 months for the combo versus the single agent, with a hazard ratio of 0.79. So that was, again, a secondary endpoint, but very interesting data for the first time showing that if you were on the combination and you relapse, or progress rather, you will have a longer time to progression with the next regimen if you had gotten the combo compared to PD-1 alone, nivolumab. So again, points to remember for Relativity 047's update is all of the outcomes examined still favor the combo versus nivolumab alone. The progression-free survival hazard ratio is 0.81. The 3-year PFS rate is 31 versus 27. The overall survival now for the first time hazard ratio is documented at 0.82. The 48-month survival of 52% for the combo is clearly superior to 42% for nivolumab alone. And the response rate, again, no big surprise, we heard about that previously. It's maintained at 44% for the combination versus 34% for nivolumab alone. And interestingly, the PFS2, the second progression-free survival, with subsequent therapy is superior if you got the combination initially at 42% versus 35% projected at 48 months. So very interesting data. Again, please feel free to call in with comments, concerns, or questions. And again, this is Dr. Jeffrey Weber reporting. Thank you very much for your attention.